Hello, my friends. It's Dr. Sharon with Clinic Reviews. Somebody said to me the other day, "Can you do asthma?" And I thought, well, I must have done asthma by now. And I look back, I haven't done asthma. How have I been making all these videos and I haven't done asthma? So you're going to get asthma? That's coming right up. Hello, Clinic Review families. Dr. Sharon with Clinic Reviews. Thank you for joining our YouTube channel. And Clinic Reviews is the very best NCLEX review in the entire universe, in my opinion. You can access our on-demand NCLEX review. It does cost money if you go to clinicreviews.com. We also have a streaming service and tutoring, small group tutoring. You purchase a month at a time. So there you go. I just told you all about it. So today we're doing asthma. I have people sometimes say to me, "Can you teach us about asthma?" This is not primarily a channel that teaches a lot of pathophysiology. I really focus on passing NCLEX. I do I do teach pathophysiology at times. I want this to be a channel where it can help you pass any test you have to take, whether it's an end of program standardized test that you have to take, or even if you take standardized tests throughout the course of your program. So this is primarily a testing, being successful on tests. So that's why I don't go in depth on pathophysiology. However, I will say about asthma. Asthma is just bronchoconstriction. Y'all, it's not more complicated than that. It's bronchoconstriction. The primary symptom associated with bronchoconstriction is wheezing. When the airways narrow, you hear wheezing. So you're listening for wheezing, you're looking for increased respiratory rate, you're looking for increased work of breathing. They say they feel short of breath. You really don't expect somebody with asthma to become hypoxic. Hypoxic means their O2 sat starts to drop. If their O2 sat starts to drop, that's a serious complication of asthma. It can happen, but it's not expected. I mean, if someone's having in your classroom at school has an asthma attack, they should be able to pull out their albuterol inhaler, take a couple puffs, and they should be fine. So we don't expect asthma to progress to a serious episode. It can happen, but that's not what we expect. So asthma is just bronchoconstriction. Lots of reasons it could happen. It could be an allergy. It could be an emotional response. It could be genetics. Sometimes it's called a reactive airway. And the reason it's called a reactive airway is because when people get very emotional about something, like crying or scared, sometimes all of a sudden they start wheezing. Have you ever had that happen to you? I've had that happen to me. And it's like, so for me, it was so embarrassing because I'd be like crying, right? I'm like talking to my husband, I'm crying. And then all of a sudden I'm like, I can't breathe. I can't breathe. I'm going to throw myself into a reactive airway episode right now if I'm not careful. So it can happen. That's why it's called reactive airway. People who have asthma, actual diagnosis of asthma, most people grow out of it. It tends to be a pediatric problem, and they tend to grow out of it. And then they may have a reactive airway when they get older, and they may have episodes of asthma on and off as they get older. They can have bronchoconstriction associated with COPD. They usually just call it bronchoconstriction associated with COPD. They don't always say they also have asthma. So you can see asthma in adults, and you certainly see wheezing and reactive airway in adults. If you get questions on the NCLEX, it's going to talk about asthma, but I just want you to know clinically, any adult can have a reactive airway. Any adult can have wheezing, and we need to know how to treat that. Okay. So I'm going to talk about it from an NCLEX perspective, but just understand that any adult could have these symptoms, whether they have a diagnosis of asthma or not. Okay, let's go ahead and get started. A 10-year-old child is brought to the ED with complaints of shortness of breath, wheezing, and chest tightness. So I go, okay, classic signs and symptoms of asthma. Which of the following findings would most likely indicate that the child is experiencing an acute asthma exacerbation? All right, well, other than the shortness of breath, wheezing, and chest tightness, those are enough to say they're having an acute asthma exacerbation. So what goes along with it? That's what I'm saying. Okay, what goes along with this? A productive cough with green sputum. No, that goes along with pneumonia. Stridor, heard over the upper airway. Not usually. That's not usually what happens. That's more associated with swelling of the upper airway. And swelling of the upper airway is often an allergic reaction. So that's not usually what I'm looking for. Expiratory wheezing on auscultation, that sounds like asthma to me. Fever and chills with body aches, that sounds like some kind of an infection going on. So the only one that really is associated with asthma is expiratory wheezing on auscultation. So I want you to not just go, what answer did I memorize? This is not about memorizing answers, although you do memorize the medications. You have to think about what's a short acting beta agonist, what's a long acting beta agonist, what's an inhaled corticosteroid. These are the three primary medications we're going to talk about during this time. But you have to just think practically. Just think, what is asthma? It's bronchoconstriction, which is going to be wheezing, shortness of breath, chest tightness. These are all common symptoms. A nurse is conducting a community education session about asthma. Which of the following individuals is at the highest risk for developing asthma? A 45-year-old male who smokes a pack of cigarettes per day, a 30-year-old female with a history of eczema and seasonal allergies, a 50-year-old male who exercises regularly and has no history of respiratory issues, a 25-year-old female who works in an office environment with no family history of asthma. All right, risks. Who's at risk? So I always think cigarettes is a risk for any respiratory disorder. So I'm going to leave A on the list. Seasonal allergies is often associated with a reactive airway. So allergic reactions very closely associated with reactive airway, which I told you is like asthma. So I'm going to leave B on the list. C, there's no risk factors here for asthma at all. Exercise is not a risk factor for asthma. D, no risk factors for asthma. So I'm crossing off C and D. Very common for you to be able to cross two answers off and to get it down to two. This is why I explain the way I'm thinking as we answer these questions. So I would normally pick the person with cigarettes because I'm like respiratory, I'm picking the cigarettes, right? But here's what I wanted to teach you, because it's not the person who smokes. In this case, eczema is considered it's not so much an allergic reaction, but it's an inflammatory reaction. And seasonal allergies, eczema, and asthma all go together. They just very closely go together. So it's just something that I want you to remember, that seasonal allergies, eczema, and asthma closely go together. And cigarette smoking is actually not a risk factor for asthma. Cigarette smoking is a risk factor for COPD, like emphysema or bronchitis, but it's not a risk factor for asthma. Okay. Could your airway narrow when the first time you take a puff on a cigarette? The first time you take a puff on the cigarette, y'all, you're going to bronchoconstrict like crazy because your lungs are going to go, no, tar and all that nasty stuff. So they bronchoconstricts, but over time, your lungs kind of stop reacting to this inhaled smoke, right? And so you really kind of stop bronchoconstricting. You can have chronic disease like with COPD, but cigarettes technically not a risk factor for asthma. There's a strong genetic component, and then there's an inflammatory component, and so that's why B is the person who's at risk. A patient with asthma is prescribed an albuterol inhaler. Which of the following statements by the patient indicates a need for further teaching? So albuterol is our short-acting beta agonist. Short-acting beta agonist. It's our rescue inhaler. If you don't know albuterol is the rescue inhaler, you need to know that for the NCLEX. You need to know that for any standardized test you take. There's no more fundamental respiratory question you can be asked, okay? All right, we're looking for further teaching, which means we're looking for the false statement. I should use my inhaler before exercising to prevent asthma symptoms. That's not a bad idea. I mean, that's okay. I should take 2 puffs of my inhaler if I feel short of breath. Well, it's a rescue inhaler. So yeah, that's when you take it. I can use my inhaler every 4 to 6 hours as needed for asthma attacks. It's not ideal. I mean, you're certainly hoping they're not going to have asthma attacks every 4 to 6 hours. They're not being very well controlled, but they can use it every 4 to 6 hours. I should use my inhaler every morning to prevent asthma attacks. Okay, we're looking for the one that requires further teaching. So we're looking for the false statement. So A is fine. B is fine. C is not ideal, but it is a true statement. D is not true. You don't use a short-acting beta agonist. You don't use a rescue inhaler unless you're having an asthma attack. It's not to prevent an asthma attack. It's when you're having an asthma attack. That's what albuterol is for. It's when you're having an asthma attack. It's a rescue inhaler, and that's when you use your albuterol. A nurse is assessing a patient with asthma who is experiencing severe shortness of breath, cyanosis, and difficulty speaking. The nurse recognizes these symptoms as indicative of which of the following complications. All right, they have asthma. So I would expect wheezing, shortness of breath, increased respiratory rate. Those are common symptoms of asthma. What are not common symptoms of asthma are severe shortness of breath, cyanosis, and difficulty speaking. Those are very severe symptoms. Those are not the common symptoms of asthma. So which could it be? What is this an indication of? Status asthmaticus, pneumonia, COPD, or pulmonary embolism? Well, we might say, could it be pulmonary embolism? Because we're always going, well, could be this. All right, well, could it be pulmonary embolism? So if I'm going to pick pulmonary embolism, I'm going to look for the classic signs and symptoms of pulmonary embolism. And do you know what one of those is? It's chest pain. And they're not having any chest pain. And remember that the NCLEX is testing on general principles, and they're not going to put like out there symptoms. And classic signs of pulmonary embolism is chest pain. It also is more likely that they would tell me they'd either just had surgery or they'd just been on a long flight or something like that. They're not going to make me pick pulmonary embolism out of the air just from any general respiratory symptoms. That's too extreme of a diagnosis. So I'm going to cross that off. COPD, okay, severe shortness of breath, cyanosis, and difficulty speaking. That's not classic signs and symptoms of COPD. It could be a sign of respiratory failure, but COPD and respiratory failure are not synonyms, y'all. Respiratory failure is respiratory failure. COPD is COPD. They're two different things. So I'm crossing COPD off. Pneumonia, if they told me they were coughing, if they told me they had a fever, if they told me they were sweating, maybe I would pick pneumonia, but none of the classic signs and symptoms of pneumonia are there. So what is status asthmaticus? Status asthmaticus is when asthma cannot be reversed. So you're having an asthma attack. You use your inhaler and it just keeps getting worse. Y'all, that isn't expected. So when asthma goes in the wrong direction, when we can't get it reversed and it goes in the wrong direction, that's what's called status asthmaticus. Status asthmaticus is when you're like, you're having this, it's not just an attack anymore. Like, this is where you're at. This is not getting any better. So I just wanted you to know that term. I wanted you to know the term status asthmaticus, because the signs and symptoms of asthma are wheezing, shortness of breath, coughing, increased respiratory rate. These are common signs and symptoms of asthma. But what we don't expect asthma to do is go to status asthmaticus, which is a complication of asthma. Okay, if you don't understand the difference between common symptoms and complications, you need to study up on the difference between those things, because those are different things. Symptoms and complications are two different things. I've talked about them in other videos. So if you kind of get in the habit of listening to my videos and you listen to the way I think and the way I explain things, it's going to start to make more sense to you over time. A patient with asthma reports experiencing nighttime coughing that wakes them from sleep. The nurse understands that this symptom is most likely related to GERD, poorly controlled asthma, viral respiratory infection, or chronic bronchitis. Now, all of these problems can awaken this person from sleep with a cough. You can awaken from sleep with a cough with GERD. In fact, a chronic cough, if you don't know this, a chronic cough, one of the most common differential diagnoses for a chronic cough is GERD. And so often they will, when someone comes in with a chronic cough, you don't have to know this for NCLEX, by the way, I'm just telling you clinically, someone comes in with a chronic cough and they don't seem to have any other symptoms like respiratory symptoms. They often will put them on an antacid, like a proton pump inhibitor, to see if they can get rid of the cough. And a lot of times it works. So GERD certainly can cause a cough. Poorly controlled asthma can certainly cause a cough. Viral respiratory infection certainly can cause a cough. Chronic bronchitis certainly can cause a cough. So how am I supposed to differentiate between these four? So here's what I want you to learn. Don't overthink it, y'all. This person has asthma. They have asthma. They told you that for a reason. Pick the one that goes with the patient's problems. If they come in, you know they have asthma, And they're like, man, and you say, how you doing? They're coming in for their, maybe their 6-month evaluation. How you doing? Man, I've been waking up a lot in the middle of the night coughing. Really? So you're just okay. So let's talk more about how you've been managing your asthma then. So don't immediately go, they must have pneumonia, or they must have the flu, or they must have something, right? Like, don't go there. Like, think maybe maybe their asthma is not well controlled. A patient with asthma is prescribed a corticosteroid inhaler, which is used to manage asthma. It's not a rescue inhaler. Corticosteroid inhaler is used to manage it. It's taken every day, just regularly, and it's not a rescue inhaler. So don't tell them to pull out their corticosteroid inhaler when they're short of breath. All right, patient with asthma is prescribed a corticosteroid inhaler. Which of the following instructions should the nurse include when teaching the patient about this medication? Use this inhaler immediately when you start feeling short of breath. No. Rinse your mouth with water after each use of the inhaler. Yes, because it can cause oral thrush. Okay, that steroid can cause oral thrush if you don't rinse your mouth out afterwards. Take this medication on an empty stomach. It's inhaler. You don't take it, like you inhale it. So no. Use the inhaler before using your rescue inhaler. No, actually, if you're taking two inhalers, you always use your rescue inhaler first because it bronchodilates. And then you take whatever the other inhaler is. You always take the other inhaler second, and your rescue inhaler is always first. So the one that I want to make sure I teach them about is that they rinse their mouth after they use it. And corticosteroids inhalers are the only ones I teach that for. I don't teach that with albuterol. I don't teach that with salmeterol. The nurse is developing a care plan for a patient with asthma. Which of the following is the most important goal to prevent asthma exacerbations? All right, so we're writing a care plan. What's our goal for a patient with asthma? We don't want them to have exacerbations. Patient will participate in daily aerobic exercise. There's nothing wrong with that, but it's not going to prevent exacerbations. Patient will reduce fluid intake during exacerbations. No, that has nothing to do with it. And we're trying to prevent exacerbations. So reducing fluid during an exacerbation has nothing to do with preventing an exacerbation. So I'm crossing off B. Patient will use the rescue inhaler when short of breath. Yes, I definitely want to do that. Patient will identify and avoid asthma triggers. Okay, so I like both C and D, but when I get it down to 2 and I'm not sure which is the better answer, I go back and I reread the question. Let's just reread the last sentence. Which of the following is the most important goal to prevent asthma exacerbations? So let's take that statement and associate it with the answer. To prevent asthma exacerbations, I want to make sure they use the rescue inhaler when they're short of breath. Well, that's not preventing asthma exacerbations. That's treating an asthma exacerbation. To prevent asthma exacerbations, I will teach them to identify and avoid asthma triggers. Well, that's preventing asthma exacerbations. That's not treating it, that's preventing it. And the question is about prevention. Okay, so I want them to identify and avoid asthma triggers. If you've taken NCLEX before, or you've taken standardized tests before in your nursing school and you haven't done well on them, please think about whether you're reading the questions carefully, because sometimes we read a question and all we really process is this is asthma. And then I go, oh, they have to use their rescue inhaler when they're short of breath. And so I pick that and I get it wrong. I'm like, why did I get that wrong? Because you didn't read the question carefully. Y'all, I do get people that say to me, these questions are so easy. They're easy because I'm doing them with you, y'all. If you turn the volume all the way off and just did these questions and read them as quickly as you usually read them, and you think about them the way you usually think about them, I'm pretty positive most of you would miss some of these answers because you haven't gotten in the habit of reading carefully and processing these things. You think you just have to memorize every answer. That's what you think you have to do. And that's totally wrong. It's not about memorizing every answer. Yes, you have to have certain things memorized. And that's what the Blue Book is all about. I've done all these Blue Book videos to help you learn facts. But so much of the NCLEX is about thinking through the question and what is it really asking you, and what is the most important goal for prevention, not just asthma in general, but for prevention. A nurse is teaching a client about the correct technique for using a metered dose inhaler. Which of the following steps should the nurse include? Now, a metered dose inhaler is like an albuterol or a salmeterol. Okay, so it's just a typical inhaler that you see people using. So what's the The following steps should be included. So I'm looking for true statements. Shake the inhaler well before each use. Yep, I like that one. Breathe in quickly and deeply. Breathe in quickly and deeply immediately after pressing down on the inhaler. Actually, it's supposed to breathe in slowly and deeply. You're not supposed to like that. You're supposed to go it's a slow, deep inhale. So not quickly is not correct. Hold your breath for about 10 seconds after inhaling the medication. That's true. 10 seconds is how long you're supposed to hold it. If it says 2 or 3 seconds, that's wrong. 10 seconds is right. Exhale forcefully immediately after inhaling the medication. No, you exhale forcefully right before inhaling the medication, not after. Otherwise, you're blowing it all out. Rinse your mouth with water after using a corticosteroid. Yes, we know E is correct. We've already talked about these. So these are the correct statements for this select all that apply question. A client with a history of asthma is admitted to the ED. The nurse notes that the client is dyspneic. Dyspneic means short of breath with a respiratory rate of 35. That's very high, y'all. People who have a respiratory rate of 35, they're not going to stay there for very long before they become exhausted. So 35 breaths a minute. Nasal flaring, which is an indication that they're struggling, and use of accessory muscles, another indication that they're really struggling. So this person's really struggling. Auscultation of the lung fields reveals greatly diminished breath sounds. Which should the nurse do first? Y'all, this is a first question, not a best question. So let's see which ones we want to do and then which one we want to do first. Initiate oxygen therapy as prescribed and reassess the client in 10 minutes. Well, I would initiate it as prescribed. The problem is I don't have an O2 sat. So because I don't have an O2 sat, I really cannot prioritize as first giving them oxygen therapy. I just can't, y'all. And I'm telling you how to test. I'm not telling you how to be a nurse. In real life, would you slap that oxygen on? I'm sure you would in real life. What I'm telling you is on the NCLEX or on a standardized test, if they don't tell you what the O2 sat is, just being dyspneic is a subjective finding. Respiratory rate of 35 is objective. Nasal flaring is objective. Use of accessory muscles is objective. And the fact that they have very diminished breath sounds is objective. But the dyspnea, that's subjective. We don't have an O2 sat, and oxygen is for O2 sats that are low. So I can't say I would do A first. Draw blood for an arterial blood gas. I would want to do that for sure. I'm just not sure I would want to do that first. Encourage the client to relax and breathe slowly through the mouth. I mean, I'd want to do that. Administer bronchodilators as prescribed. Okay, y'all. They have a history of asthma, which is bronchoconstriction, right? I could put oxygen in them all day long, but if they're bronchoconstricted, they're not going to get it. I have to bronchodilate, and their lungs are greatly diminished. If they have no lung sounds, like you're not even hearing wheezes, y'all. If you're not even hearing wheezes, it's so diminished you can't hear anything. They are so constricted. There's no air moving. You have to first do the bronchodilators. I'm telling you how to take a test. In real life, you would have about 5 people there. Everybody, one person would be putting them on oxygen, one person would be getting the bronchodilator ready, one person would be getting the IV in, one person would be drawing the ABGs. I know in real life that's how it would be doing. On the NCLEX, they want to know if you can think critically and understand what's really going on. When they say, what would you do first? They're saying, what needs to be done first here? What's the problem? And it's bronchoconstriction. So we got to give them that bronchodilator. Client with asthma is prescribed. By the way, this is one of those times where first and best would be the same answer. First and best would be the same answer in this particular case. Client with asthma is prescribed an albuterol inhaler, which is a short-acting beta agonist, and a fluticasone inhaler, which is an inhaled corticosteroid. Okay. Fluticasone, whenever you see "sone" at the end, like prednisone, whenever you see "sone," even if it didn't tell you corticosteroid, you should know that's a steroid. Erol, EROL at the end, like albuterol, salmeterol. These are all beta agonists. So albuterol is a short-acting beta agonist. Salmeterol is a long-acting beta agonist, whereas fluticasone, the sone, is a corticosteroid. Which instruction should the nurse include when teaching the client about the use of these inhalers? Use fluticasone inhaler first, then wait 5 minutes before using the albuterol. Use the albuterol first, then wait 1 minute before using the fluticasone. Use both inhalers simultaneously. Well, that's not possible. That's not possible. So C's out. Doesn't matter which inhaler. It does matter. D is out. So I told you this a couple of questions ago. Do you remember what I told you you had to do? You have to use the albuterol inhaler first. And you might have been thrown off because you might have gone, but only wait a minute. You only got to wait a minute. That's fine. Waiting a minute is fine. It works really fast. Albuterol is a rescue inhaler because it works really fast. Okay. So waiting a minute is fine. So you have to use the albuterol. If you have two and you got to take them both, you have to use the albuterol first. It doesn't matter which meds you're taking, albuterol you have to use first. Client with COPD is prescribed a long-acting beta agonist. Which statement by the client indicates a need for further teaching? A long-acting beta agonist. It could have said asthma in the same thing. So this is really the meds that are used to treat COPD and asthma are essentially very similar meds. They just tend to switch them around a little bit. Like I think corticosteroids are more often used with asthma, and long-acting beta agonists are more often used with COPD, but they can be used interchangeably. All right, which statement by the client indicates the need for further teaching? So I'm looking for the false statement. False statement. I will use this inhaler for quick relief if I have trouble breathing. Well, that's false. It's a long-acting beta agonist, not a rescue inhaler. I will use this inhaler every day, even if I feel well. Well, that's true. That's given as management, daily management. You're supposed to take it every day. This inhaler helps to keep my airways open over a long period. That's true. That's why it's a long-acting beta agonist. I will take my long-acting beta agonist inhaler as scheduled and not skip doses. Well, that's good. That's true. That's exactly what you should do. So it's not a rescue inhaler. So this may not seem like complicated information to you, but y'all, you have to know the difference between a long-acting, a short-acting beta agonist, and the corticosteroid. The corticosteroids end in -sone, fluticasone. The rescue inhaler, the only one is the albuterol, and the long-acting beta agonist ends in -erol as well. Salmeterol is an example of that. So those are the three meds you really have to know for inhalers. A nurse is teaching a client about the side effects of an inhaled corticosteroid. Which of the following side effects should the nurse mention? Tachycardia, muscle cramps, oral thrush, or hypertension. So if you don't know this, an inhaled corticosteroid is a powdered inhaler. So it's a circle. It looks like a circle. And you really don't have to shake it. You click it, you move it over and you click it, and then you blow out and you inhale it quickly. This is a powdered one, not a metered dose inhaler. The metered dose inhaler is slowly, but the powdered inhaler is quickly. And that's why you have to rinse your mouth out afterwards, because this powder can get left in your mouth and it can cause oral thrush. Okay. A nurse is instructing a client on the use of a dry powder inhaler. Okay, well, I just told you about it. Dry powder inhaler as opposed to a metered dose inhaler, which is albuterol, salmeterol, are metered dose inhalers. This is a dry powder inhaler. Which statement by the client indicates understanding? So I'm looking for the true statement. I need to shake the inhaler well before using it. You don't have to shake it, a dry powder inhaler. I should exhale into the inhaler to load the medication. No, you don't exhale to load it. You just click it over. I will take a quick, deep breath to inhale the medication. That's exactly right. I should clean the inhaler by washing it with water after each use. No, you don't have to do that. So which statement by the client indicates understanding? You have to take a quick, deep breath to inhale the medication. So metered dose inhalers are a slow, deep breath. Dry powdered inhalers are a quick, deep breath. A nurse is teaching a client about using a spacer with a metered dose inhaler. What is the primary benefit of using a spacer? If you don't know what a spacer is, just Google it. It's blue and it's attaches to the end of the inhaler. It goes with a metered dose inhaler, not a dry powder inhaler. So you just stick it to the end. And when you exhale and then you pump it, you wait fraction of a second, pump. So you don't inhale at the same time, because if you're not using a spacer, you inhale as you pump it, right? But when you use a spacer, you pump and then you inhale, and that's because it has to get into the spacer for you to inhale it. All right. And there are these, so I'm not a pharmacist, so I don't want to tell you the wrong thing, but there's something about these metered dose inhalers. The medication is encapsulated in these very small beads, right? You really can't see them with the naked eye. But apparently, for people who have trouble getting the medication into their lungs, when you use a spacer, it helps to break up those beads so you're getting the medication in, more immediate medication in, as opposed to like the beads. I don't understand it completely, but that's the point of using a spacer. Okay. What is the primary benefit? It increases the speed of medication delivery. That's not what it does. It eliminates the need to hold a breath. No. It makes the inhaler easier to use in an emergency. No. It helps to ensure more medication reaches the lungs. That's what it does. And so I just wanted to teach you that. This is just a fact for you to know. It helps ensure more medication by breaking those beads. And I don't know how it does it, but it breaks those beads and it allows more medication to reach the lung. Apparently, when you're not using a spacer, it has a tendency to hit the back of your mouth and your throat, and those beads break open instead of getting all the way to your lungs. I don't know. Google it if you want to know more than that. A nurse is reviewing discharge instructions with a client prescribed an albuterol inhaler. Which of the following instructions should the nurse include? So we're looking for a true statement for albuterol, which is the rescue inhaler. Use this inhaler every morning and night, even if you don't have symptoms. False. It's a rescue inhaler. You use it when you have symptoms. Take a dose of your inhaler at the first sign of wheezing or difficulty breathing. True. That's when you use a rescue inhaler. This inhaler can be used as often as needed for symptom relief. No, that's not true. There is a limit on how often you can use it. It's like every 4 to 6 hours. You can use 2 puffs, I think, every 4 to 6 hours. So it's not as often as needed. Store your inhaler in the refrigerator. It does not need to be kept in the refrigerator. So you should take a dose at the first sign of wheezing or difficulty breathing. And they can't, if they're using it more often than every 4 to 6 hours, y'all, there's a problem. Like they're not being managed well. They need to come in and see the doctor and get on some kind of a daily medication, like a corticosteroid or a long-acting beta agonist, something. Like something's not going right here for them if they're using it more often than every 4 to 6 hours. Okay. So I know that wasn't super complicated, but it's the really critically important information you need to know about asthma and about the medications for asthma. Could you get other questions that are not just like these? You could, but they're going to be really simple. They're going to cover similar things. So I honestly did teach you what you really need to know about asthma. It's bronchoconstriction. You need to think of it as wheezing. If the louder the wheezing, the better it is. So as the wheezing gets softer and softer and softer, and then the lungs become diminished and there's no sound at all, that's bad. So loud wheezing is better than quiet wheezing. Okay. Status asthmaticus is when you can't reverse the asthma attack. You have short-acting and long-acting beta agonists. Short-acting beta agonist is the albuterol that's used as a rescue inhaler. The corticosteroids are used on a daily basis, as well as the long-acting beta agonist. Either one or both could be used on a daily basis to prevent the symptoms. And you need to teach them how to use the inhalers. And I don't know, I talked about a couple other things, I think. So that's about it. I hope you have a great rest of your week. I don't know if you're watching this on the weekend, during the week, at night, in the morning, in the middle of the night, whatever it is. Love you. Hope you have a great rest of the time, that you are alive today. See you later.